Hi everybody, and welcome to our module on placental pathology. Let's start by talking about placental abruption, which is also sometimes called abruptio placentae. This refers to placental detachment prior to delivery of the baby. So normally after the baby is delivered, the placenta detaches, but if this occurs before delivery of the baby, that's a placental abruption. When this happens, there's blood loss from maternal vessels, and there's loss of gas and nutrient exchange to support the fetus. In addition, the blood causes uterine contractions, so this can initiate the process of labor. And this is a life-threatening condition for both the mother and the fetus. The baby loses its nutrient supply from the placenta, and the mother can exsanguinate from blood loss. The strongest risk factor for placental abruption is a previous pregnancy with an abruption, and this is true for many conditions in obstetrics. If a woman has had the condition with a prior pregnancy, she's more likely to have it again. It's also more likely for placental abruption to occur if there's chronic disease involving the placenta. So mothers who have hypertension or preeclampsia have underperfusion of the placenta, and this can lead to abruption. Smoking and cocaine are both vasoconstrictors. They lead to less blood flow to the placenta, and that can cause an abruption. It's also more likely that placental abruption will occur if there's something abnormal about the uterus. So women with structural anomalies of the uterus, like a bicornate uterus, are more likely to have abruption, and women who've had a prior C-section and have scar tissue in their uterus are also more likely to have abruption. You can rarely see a placental abruption caused by trauma, for example, if a mother is in a motor vehicle accident. And then anytime the uterine cavity decompresses rapidly, this can cause an abruption. So for example, when one twin is delivered, the placenta can sometimes detach, which can compromise the health of the second twin. Placental abruption usually occurs in the third trimester, although it can sometimes also happen in the second trimester. And the classic presentation is the abrupt onset of painful vaginal bleeding of a woman in the third trimester of pregnancy. The pain can be abdominal or back pain depending on the location of the placenta and the blood loss, and there are also usually uterine contractions, as I mentioned earlier, from bleeding. Often this is a clinical diagnosis. In any woman who presents with pain and bleeding in the third trimester, you have to consider that she may have a placental abruption. Ultrasound is not reliable for diagnosis, but when ultrasound is diagnostic, the classic finding is the presence of a retroplacental hematoma, and there's an example of this shown on the slide here. And then you should be aware that MRI can be used for imaging in some cases, especially if the mother is stable and the diagnosis is unclear. A subset of placental abruptions are called concealed placental abruptions. In these abruptions, there is minimal or no bleeding because the blood becomes trapped between the membranes and the decidua. And this occurs in about 20% of women who develop placental abruption. When this happens, there won't be any vaginal bleeding, but there will be uterine contractions from the blood loss, so this will present as a woman in preterm labor. But what will be different from the usual preterm labor is that she won't just have uterine contractions, there will also be severe focal pain at the site of the placenta, and the uterus can be tender and rigid. So these features of a woman in preterm labor suggests that she could have a concealed placental abruption. The major complications of placental abruption, and the reason it's a life-threatening condition, are because first of all, the mother can go into shock from the blood loss. The fetus can develop fetal distress or demise from losing the support of the placenta. And then lastly, it's very common for placental abruption to trigger disseminated intravascular coagulation. An abruption is a classic trigger for the onset of DIC. If you think a woman is having a placental abruption, the management begins with initiation of fetal heart rate monitoring, and then you need to establish intravenous access in the mother so that she can receive IV fluids and possibly blood transfusions. If the mother is unstable, the treatment is with cesarean delivery. So for example, if the mother is hypotensive from blood loss, or if she has evidence of coagulopathy on lab testing from DIC, these are all indications for an urgent cesarean delivery. If, on the other hand, the mother is stable, this is a very tricky situation in obstetrics as far as the management. Vaginal delivery is possible, but cesarean delivery is also often done. This varies based on multiple factors, including the fetal status and the weeks of gestation of the pregnancy. There's a special renal complication of placental abruption that you should know about called cortical necrosis. It gets this name because in cortical necrosis, there's ischemic necrosis of the renal cortex. This is a rare cause of acute renal failure. It's associated with ischemia and DIC, and therefore it often occurs in women who have placental abruption. The presentation is as acute renal failure in a woman with placental abruption. There's often anuric renal failure, so no urine will be produced. You can see hematuria, sometimes it's gross, and the woman can also have flank pain. And the management is the same as the management of most forms of acute renal failure, but you should be aware, especially for your boards, that cortical necrosis is a special cause of acute renal failure, often seen in women with abruption. Next, let's talk about placenta previa. So the word previa means going before. So in a placenta previa, the placenta comes before the baby. It looks like this drawing on the screen here. The placenta is attached to the lower uterus over the cervical os. When this happens, if the baby is delivered vaginally, it will break through the placenta, and that can cause fetal demise. It can also cause the mother to exsanguinate. So vaginal delivery in a woman with a placenta previa is a very dangerous situation. And if you want to watch an excellent TV series, watch The Nick, K-N-I-C-K, The Nick on Cinemax. It's about life in a hospital in the early 1900s, and women in those days who had placenta previa often died during childbirth, as did their baby. So a normal placenta is at least 2 centimeters away from the cervix. In this situation, it's safe for the baby to be delivered vaginally. In a complete or total placenta previa, the cervix is completely covered by the placenta. That's depicted in this image here, with the placenta covering the cervix entirely. In a partial placenta previa, the placenta partially covers the cervix. That's what's shown here. And in a marginal placenta previa, the margin of the placenta extends right up to the edge of the cervix. And then lastly, some women have what's called a low-lying placenta. This is where the edge of the placenta is less than 2 centimeters from the cervical os. It's not technically a marginal placenta, but it is a placenta that's at risk for complications at the time of delivery. Major risk factors for placenta previa are shown on this slide. So any woman who's had a prior placenta previa in a previous pregnancy is at increased risk to have another one in subsequent pregnancies. Anytime there's been scarring or potential damage to the uterus, this also raises the risk of placenta previa. So women who've had prior C-sections have scar tissue in the uterus. Women who've had multiple prior pregnancies can have abnormalities of the uterus from the pregnancies. And women who've had previous uterine surgeries, for example, a myomectomy for a fibroid, these women also are at increased risk of a placenta previa. In modern practice, most placenta previas are detected on routine prenatal ultrasound. This is one of many reasons that we do lots of ultrasounds in pregnancy, so we can detect things early like placenta previa. Now the good news is that most placenta previas, 90%, resolve spontaneously. The placenta can shift its position throughout the course of pregnancy. So when a previa is detected early in pregnancy, usually you simply continue routine care and monitor the patient. In 90% of cases, the placenta previa will resolve by the time of delivery. Because the placenta is overlying the cervix, sometimes there can be some bleeding during pregnancy when women have a placenta previa. This will be painless bleeding, and this can occur in women with a previa. You should also know that placenta previas are associated with an increased risk of a preterm delivery compared to normal placentas. Now, in women who have not had routine screening ultrasounds who present with painless bleeding, the diagnostic test of choice is pelvic ultrasound. This is done anytime a woman presents with second or third trimester bleeding, whether she's known to have a placenta previa or not. And importantly, when a woman presents with painless bleeding, you want to do the ultrasound before the manual exam, because a manual exam can potentially cause worsening bleeding from a placenta previa. And then besides being able to diagnose the placenta previa, ultrasound can also evaluate for a coexisting placenta accreta, which we're going to talk about later. This is a form of abnormal implantation of the placenta into the uterus, and it often occurs together with placenta previa. And just to emphasize this management point I mentioned earlier, when a placenta previa is identified early in pregnancy, it's followed with ultrasound because it may resolve with time. In particular, the anterior wall of the uterus, shown here, expands more during pregnancy than the posterior wall. So anterior placenta previas are more likely to resolve. As that wall expands, it often pulls the placenta away from the cervix. Besides serial ultrasounds, placenta previas are managed by advising women to reduce the bleeding risk. They should avoid sexual activity because this can cause bleeding. They also should avoid strenuous activity and prolonged standing, both of which are also associated with increased bleeding. When women have acute bleeding episodes, they're treated with IV fluids or sometimes blood transfusions. And anytime there's a significant bleed, usually the woman is hospitalized until delivery, so she can be kept under careful monitoring. And then for placenta previas that persist as the woman is approaching term, these women must have a scheduled cesarean delivery. Vaginal delivery is contraindicated. Usually a scheduled C-section is done around 36 to 37 weeks. A C-section is also done if the patient enters labor early. Next, let's talk about a vasoprevia. This refers to a pregnancy in which the fetal blood vessels are located near the cervical os. This is a drawing of what it can look like on the screen here. You can see the vessels overlying the cervical os. When this happens, when the membranes rupture at the time of labor and delivery, this can lead to bleeding. And so just like a placenta previa, a vasoprevia usually requires a C-section delivery. And in most cases, vasoprevias are associated with a velamentous umbilical cord. So let's talk about that now. Normally, the umbilical cord inserts into the center of the placenta, but in a velamentous cord, the umbilical cord inserts into the fetal membranes and then travels with the fetal membranes to the placenta. When this happens, the fetal vessels are exposed. They're not protected by Wharton's jelly like they usually would be, and this makes them prone to rupture and bleeding, and the fetus can exsanguinate in minutes once there's a rupture of membranes with a velamentous umbilical cord and these vessels are torn. And this is a picture of what a velamentous umbilical cord looks like. You can see the fetal vessels traveling within the membranes, and you can imagine that when these membranes rip or tear, they can tear this vessel, and that can very quickly lead to fetal demise. In modern practice, vasoprevia is usually diagnosed by a prenatal ultrasound. Prenatal ultrasound can easily identify where the fetal vessels are, and if they're within 2 centimeters of the cervical os, that meets criteria for a vasoprevia. Most cases of vasoprevia also have a velamentous cord or a placenta previa, and these things can also be seen on ultrasound. If a vasoprevia is undetected prior to labor, for example, in a woman who had no prenatal ultrasounds during pregnancy, then the presentation is painless bleeding at the time of membrane rupture. This will very quickly lead to fetal distress, which can be detected by fetal heart rate monitoring. It can also very quickly lead to fetal demise. And if you do tests of the bleeding at the time of rupture of membranes, you can identify that the bleeding is coming from the fetus. There are a couple of tests that can be performed for this purpose. One's called the Apt test, another is called the Kleihauer-Betke test. But either of these will show that the blood is coming from the fetus at the time of membrane rupture and not from the mother. In many cases, fetal distress is so rapid that there isn't time to perform these tests of the blood. So the classic case to know for your board exams is a woman who has no prenatal care and she presents with bloody rupture of membranes and evidence of fetal distress or fetal demise. When vasoprevia is identified prenatally, the treatment involves betamethasone at 28 to 32 weeks to improve surfactant production in the baby, then hospital admission for fetal surveillance, and cesarean delivery is done before rupture of membranes, usually around 34 to 35 weeks. In cases where there is no prenatal diagnosis and the vasoprevia is identified at the time of labor and delivery, an emergency C-section is done when there's rupture of membranes and the woman enters labor. Next, let's talk about abnormal attachment of the placenta to the uterus. So normally the placenta attaches to a layer of the uterus called the decidua that forms during pregnancy. This is depicted in this image on the screen here. The placenta in purple is attached to this orange layer of the uterus, which is the decidua. If the decidual layer does not form normally during pregnancy, then there will be abnormal attachment of the placenta to the uterus. Without a normal decidual layer, the placenta can attach directly to the myometrium, and this is going to lead to major problems with bleeding after delivery of the baby when the placenta tries to detach. And there are 3 forms of abnormal attachment. The most common is called placenta accreta, the others are placenta increta and percreta, and we'll talk about all of these in just a minute. So as I said on the last slide, the cause of abnormal placental attachment is defective uterine decidualization. The layer of the uterus that lines the uterine cavity undergoes a process called decidualization to prepare for attachment to the placenta. If that process is defective or abnormal, then the placenta is going to adhere directly to the myometrium. The most important risk factor is a prior C-section. Women who have had a prior C-section have scar tissue in their uterus, and this can lead to abnormal decidualization in the area of the uterus around the scar tissue. And if that's where the placenta attaches, that can lead to these attachment problems. Women are at especially high risk if they've had a prior C-section because of a placenta previa. Women who have a placenta previa have a tendency to have the placenta form in an abnormal location, and then so if on top of that they've had a C-section, they now are at high risk for abnormal attachment. Other risk factors are anything that can lead to scar tissue in the uterus, things like uterine surgery or a D&C. So let's talk about the 3 subtypes of abnormal attachment. We already talked about the normal situation where the placenta adheres to the decidual layer of the uterus. In placenta accreta, which is the most common form of abnormal attachment, the decidual layer doesn't form normally, so the placenta adheres directly to the myometrium, but importantly, it doesn't penetrate the myometrium, it just sticks to the myometrium itself. In placenta increta, the placenta penetrates into the myometrial wall, and then finally in placenta percreta, the placenta penetrates through the myometrium and into the outer layer of the uterus called the serosa. It can even go all the way through the uterine wall and attach to structures like the bladder or the rectum. In modern practice, abnormal placental attachment is usually identified by prenatal ultrasound. If it is undetected, the presentation is that the placenta will fail to detach after birth. Part or all of the placenta will remain behind, attached to the uterus. The placenta will break into pieces, and this usually leads to massive bleeding. And in the video on postpartum, I talk about postpartum hemorrhage due to retained pieces of the placenta, and a major cause of that phenomena is abnormal attachment. This can lead to massive maternal hemorrhage after delivery of the placenta and other clinical features like shock and DIC or ARDS. So because of the risk of bleeding and these complications, delivery is usually by C-section, and in many cases, unfortunately, hysterectomy is required because there's simply no other way to control the bleeding after delivery of the baby. Let's finish by talking about uterine rupture, which is rupture of the uterine wall. This can occur as a complication of labor and delivery when the uterus is contracting and the mother is pushing. In rare cases, this can lead to rupture of the uterus. It's often associated with prior uterine surgery, often a prior cesarean section. As I've already mentioned in this video, this leaves scar tissue behind which can weaken the uterine wall, and this can be a setup for a uterine rupture. Uterine rupture usually occurs during labor. It presents as a sudden worsening of abdominal pain, and the uterine contractions associated with labor will become irregular and have decreased intensity because the uterus has ruptured. There can be vaginal bleeding. There can also be lots of abdominal bleeding in uterine rupture, and this can lead to shock in the mother. Now, some of these features, especially abdominal pain and vaginal bleeding, can make you think of other diagnoses like placental abruption. But some of the unique features of uterine rupture are, first of all, that there's a sudden loss in fetal station. So if the fetus has descended into the pelvis and the birth canal, and the fetal station is positive, and suddenly that fetal station is lost and becomes negative, that suggests a uterine rupture. Also, fetal parts can protrude through the rupture in the uterus, and this can cause protuberance of the abdomen. So especially when you're answering board questions, if you see a description of a sudden loss of fetal station and protuberance of the abdomen, those features should make you think of uterine rupture. There can also be evidence of fetal distress, things like fetal bradycardia with late or variable decelerations, and the treatment is to perform an emergency laparotomy and a cesarean delivery. And that concludes our module on placental pathology.